So yeah, the topic, I mean, first of all, this is a great initiative, and I really am fortunate and honored that I've been invited to give this presentation and be part of the movement, which I'm every time I come in contact with friends and colleagues, there is definite development and progress in how dialysis treatment is provided in India. So this is very welcoming change from my perspective. And again, thank you so much to both Umesh, Rajesh, and all the organizers who have put up such a fantastic program. I wish we had all our patients had vessels like this. I mean, these are actually normal patients that I have come across, or normal people I have come across. The arm in the left-hand panel is that of a physical therapist who works at my hospital, and this is one of my colleagues who has an excellent vein, as you can see. I mean, having veins like this in our patients is a dream, which would certainly avoid the need for catheters that we have to depend on for a large number of our patients. So the way I am going to talk about the catheter overview is catheter as a vascular access, a brief anatomy of central veins, so that the technicians will know where these vessels, which vessels are used and how and where the catheters are placed. Some details about catheter designs. All of these catheter designs, I'm not sure whether they are available in India or not. And finally, I'm going to concentrate mainly on the common complications that they will encounter when they are trying to treat patients and hook up patients for dialysis. So in general, the central venous catheters are, we would like to use the terms non-tunneled and tunneled. We don't like to use the term permanent. It's actually a bridge. Tunneled catheter is a bridge to a permanent AV access or a long-term AV access, which is essentially AV fistula or an AV graft. Non-tunnel catheters are generally placed in an acute indication, and most patients, at least here in the US, we would not leave the catheter in for more than 10 or 14 days. After that, the patients are switched over to a tunneled catheter. But I know the situation in India is different. Different regions have different challenges, and I've heard stories about patients maintaining a non-tunneled catheter for 2-3 months or even longer at a time. Of course, that brings in additional issues. So when we talk of non-tunnel catheters, the most common site is the jugular vein. And for the tunnel catheters too, the common site is the jugular vein. These veins open up into the central veins, which then empty into the heart. So the tip of the catheter is generally located very close to the heart in the right side of the heart. Catheters are certainly a great advantage, but they also have a lot of challenges. So it helps in dialyzing and providing immediate dialysis in an emergent situation. And there's no maturation time, unlike in a fistula, where the fistula requires anywhere from 3 to 4 weeks after surgery to be used. On the other hand, the catheter comes in with a lot of complications. There are patency problems, infection problems, and if the catheter is left in place for a longer period of time, there is central vein stenosis. And of course, with the catheters, when something plastic is sticking out of the body, patients certainly don't like it. So if we think of it from a patient perspective, it limits patients' activities. Those who have access to swimming pool or those who want to do activities, physical activities, they certainly may have some limitations. And I know this is a complex slide, but what I really want to highlight here is patients who dialyze with catheter and patients who dialyze with an AV fistula, their mortality is totally different. The patients who dialyze with catheters certainly have a very high mortality compared to patients who dialyze with AV fistula. So every attempt should be made to get these patients, convince these patients to get converted or get an AV fistula as soon as possible so that the catheter can come out. A brief anatomy review here where, as you can see, this is the jugular vein, which is the commonest site in the neck, which is used for cannulation, both for non-tunneled catheter as well as tunneled catheters. The jugular vein meets with the subclavian vein and forms the innominate vein. The two innominate veins on both sides form the superior vena cava, which then opens up into the right atrium on the right side of the heart. We avoid placing catheters in the subclavian vein that's below the clavicle. The jugular vein always is the preferred site. Right is preferred compared to the left. And in the leg, as Dr. Manisha Sahai was mentioning, I think this is probably a common site where if the technicians are placing catheters, they place in the leg, in the femoral region, which is again not an ideal site for non-tunneled catheters because the risk of infection for obvious reasons is very high. From the practical perspective, what one really needs to understand is catheters that are placed on the right side clearly provide better blood flows when compared to catheters on the left side. And one has to understand the reasons. So the right side catheter is a pretty straight path straight into the heart. So as you can see, the tip of the catheter is inside the right atrium or upper part of the superior vena, upper part of the right side of the heart. Whereas on the left side, the catheter really takes multiple turns before it enters into the heart. So the blood flows on the right side are much smoother, and I'm sure in your practice you have seen that catheters that are placed on the right side provide a much better blood flow compared to the left-sided catheters. Even when the catheters are removed, you can appreciate this, that the catheter on the right side is fairly straight, whereas catheter on the left side has multiple curves, and because of these curves, the physics changes, the hemodynamics changes, and the flow is not lamellar or straight. And that leads to poor blood flows when you connect these patients to the hemodialysis machine. Now, different catheter designs are available. Again, some of these catheters, these are all non-tunnel catheters. They are available in different lengths, different sizes. They may have a preformed curve, either the entire segment or just the external extension tubes that may have the preformed curves. And in the hospital settings, oftentimes when the patient is really sick, we use a catheter that has 3 different lumens. The smaller lumen is used for providing any additional infusions of IV fluids or antibiotics or whatever else other medications are needed. The tunnel catheters, they come in various designs. They come in various different manufacturing products. The main thing that one has to be aware of is the type of tip, which is the step tip, split tip, or symmetric tip. And I'm pretty sure all of these different catheter designs are available in the Indian market. And the second big thing that is relevant from a catheter function perspective is the presence of side holes, whether they are present, whether they are absent, whether they are tiny holes, or whether they are slits. And here are some of the designs that are available in the market, at least internationally. I'm not familiar with the market names available in India, but the common ones and the cheaper ones generally have a step tip. There are split tip catheters, and there is a single tip, symmetric tip catheter, which both the lumens open at the tip. And when we look at the different side holes, again, there are catheters which have big slots or big rhomboid slits, and there are catheters which have small, tiny holes, which may be few versus many. So again, depending on the type of the catheter design, the blood flow may vary and be different. So it's good to know what catheters are being used in your particular dialysis unit. Now, I think I'll focus mainly on the complications that are very relevant when you are managing the patient all by yourself in the dialysis unit, and you need to recognize these complications and alert your physicians early enough so that measures can be taken before the patient gets really sick. The biggest challenge is to minimize and prevent the risk of infection. And there are several non-infectious complications. So poor blood flow, as I mentioned, is a major complication that often is encountered in the dialysis unit. And if the patient is not receiving good blood flows through the catheter, then obviously the dialysis treatment is going to be inadequate. And if the patient continuously receives inadequate treatment, then they can get sick, more sicker, to the point where they may then need to get admitted to the hospital. One thing I would like to highlight here, that poor blood flows often, it's a human tendency that if the red port is not working well and the blue port is working well, we just switch the lines. So we start pulling blood from the blue port and start pushing blood from the red port. Again, that's okay for one treatment or maybe two treatments, but beyond that, that has to be investigated, and one has to be cautious enough to not continuously provide dialysis by reversing the ports. Here are some of the immediate challenges or immediate reasons why the catheter may not be working. If the catheter has not been placed appropriately, so if the catheter is kinked in the tunnel, then obviously the flow is not going to be adequate. This complication generally is encountered when the patient has had a catheter placement, and in the early days, the catheter is not working. One has to start thinking in terms of, is the catheter placement appropriate or not? Kink is one problem. The other problem is the catheter is not long enough, so the catheter is not where it needs to be. It needs to be in the lower part of the SVC or in the right atrium. Here the catheter is short, so obviously this catheter is not going to work or function properly. Catheters can be, if it is placed blindly without fluoroscopy or X-ray support, then or X-ray guidance, then the catheter tip may enter into abnormally enlarged veins like the azygous veins, and here again you can see that there's a big kink which can be easily corrected if recognized early enough. The other major aspect of catheter is catheter-related infection. Now, catheter-related infections can be minor, like exit site infections, but it can turn into major problem with the infection spreading into the tunnel or infection spreading into the bloodstream. So as one can understand, catheter really is a highway for the microorganisms and bacteria to travel into the bloodstream. So here you really want to be very, very, very careful when handling these catheters. And that's something that if you take shortcuts or if you cut corners, then you are very likely to run into issues with catheter-related infections. Taking care of the exit site is very important. Routine inspection at every dialysis session. So a simple examination, making sure that the exit site is not red, exit site is cleaned properly. The skin should be cleaned with chlorhexidine if that's available in your dialysis center. That's the most preferred antiseptic solution. It is a bactericidal agent, so cleaning with chlorhexidine is ideal. If not, if that is not available, if it is expensive, then betadine or iodine is the next best solution. And as a last resort, 70% alcohol can be used. In situations where the infection rate is high within the given center, then we often use antimicrobial agent, local topical ointments to apply at the skin exit site every time the dressing is changed. What kind of dressings to be used? Again, there is no clear evidence. Whatever is available, but keeping a clean, dry gauze with tape or a transparent dressing, either one, depending on the cost and the availability, one can use. Empirical use of antibiotics early enough when the patient gets early signs of infection, such as fever, chills, should be used before using antibiotics. Again, a blood culture is absolutely essential. CDC, Centers for Disease Control, has provided basic recommendations for prevention of bloodstream infections in dialysis. So that's the core. If the patient is dependent on catheter for dialysis until the patient gets an AV fistula or an AV graft, it's imperative that we take utmost precautions to prevent bloodstream infection or bacteremia. Again, active surveillance and reporting is essential. So as was mentioned by Dr. Rajapurkar, that keeping data is important. So one has to maintain how many infections are seen every week, every month, and that data has to be maintained. So that will tell you if the infection rate is going up or down. And the goal should be, once you have a baseline data, then you can work towards improving and putting in measures to reduce the amount of the number of infections. Hand hygiene is absolutely must. I know with COVID, we have all learned to use alcohol, but it should not stop once the COVID pandemic is over. Hand hygiene is important, and hand hygiene by everyone. So whoever is going to be close to the patient should be using the alcohol. And again, oftentimes we as doctors, when we come into the unit, we forget to do it. And I think it's everybody's responsibility to remind each other. And I don't think there should be a culture where if the doctor is not using alcohol, the technician should feel free enough to remind the doctor that, hey, you've not used alcohol before touching the patient. And I think that is a big culture change. I've practiced in Bombay, and I know the technicians are all scared oftentimes, and that should not be the way to manage patients in the dialysis units. Patient education is equally important. Patient needs to be aware that they have to take care of their catheters. They should maintain cleanliness around the catheter site, avoid the catheter dressing from getting wet. And every staff member should be educated, and every measure should be taken. I think this is the most important aspect. Every measure should be taken that patients, once they get started on dialysis with a catheter, they should be informed about the better options, and they should be encouraged to get an AV fistula or an AV graft as soon as possible. I cannot emphasize on performing hand hygiene before handling the catheter. Wearing gloves, equally important, and each time you wear gloves, you first have to use alcohol and then wear gloves, clamp the catheter, disinfect the hub with the caps removed. The caps have to be changed every time. And the hub has to be cleaned for at least 15 seconds with an alcohol swab. So that way we minimize the risk of infection during the connect and disconnect phase. Same thing with the disconnection. There needs to be a proper protocol, and the protocol has to be followed by every technician in the dialysis unit every time the catheter is used. The patient has to wear a mask. Now with the pandemic, everybody's wearing a mask, but the patient has to wear a mask. The technician has to wear a mask. Anybody who's close around the bed has to wear a mask. Wear gloves, clamp the catheter, again disinfect the hub, and apply a new cap. So it's equally important that both connecting and disconnecting the catheters when from the dialysis tubings, and then capping it should be performed with a protocolized sterile technique. I'll go over some of the, I've got about 2.5 minutes to go, so I'll go over some of the common problems, clinical problems that we see in the dialysis unit. So this is an early exit site infection. These are actually easy to treat with proper cleanliness, local topical antibiotics, and the catheter can still be continued and maintained on dialysis. The key here is one has to observe and ensure that the infection and the redness is not getting worse, the tunnel is not getting infected, and there is no drainage at the exit site. You don't really want to see this. If there is a suture at the exit site, generally after 2 weeks, the suture can come out. If the suture is left in place, of course, that's a place where the secretions can accumulate, blood can accumulate, and it becomes a focus for infection. You definitely don't want to see this. If you start seeing this pus under the pus coming out from the exit side, severe tenderness, then that catheter has to come out. You cannot in any way save this catheter. And lastly, if you definitely see an abscess forming, redness around the entire neck, shoulder area, then that is pretty serious, and that really needs to be addressed as immediately as possible. The first thing to do is get the catheter out. Common other problems that we see is because of the catheter has thrombus in it. Again, here the key is to properly flush the catheters with a 10 cc syringe, fill up a 10 cc syringe, and flush rigorously so that in that extension clear tubings that you see outside on the catheter, there should be no blood visible in those tubings. It should be clear saline visible in that, and then you can lock the catheter with proper heparin solution. Catheters can form clots at the tip if they're not flushed properly. And again, if the patient has multiple other pacemakers or other catheters, then there is a lot of crowding inside the vessels, and these patients are more likely to develop clots. As you can see here, this patient developed a clot, and this catheter is not going to work properly. The catheters can also develop fibrin sheath. The longer the catheter is staying there, they develop, that's a natural defense mechanism of the body, and these catheters then need to be addressed properly with some kind of an intervention that they need to go to a radiologist or a nephrologist who's performing these procedures. These catheters, unless they are changed, will not function out. Here's an example of how the fibrin sheath, which was formed, has then been angioplasty with the balloon angioplasty, and it's opened up, and this catheter would then function to provide adequate dialysis. So take-home points here: catheter is one of the key ways in which we do dialyze, but it comes with its own set of problems. It's important that the common complications are recognized early enough, such as infection, thrombosis, and fibrin sheath formation. And aseptic care of the catheter is an absolute must. I think this concludes my talk here, and thank you again for this opportunity, and happy to take any questions at the end of this session.
Thank you, Tushar. Always a pleasure to listen to your talk. We will be taking the questions at the end.